Hello, welcome everybody attending or watching the Harvard-MIT Belgian Society Selected Webinar focused on the response against COVID-19. Before we start, I would like to briefly introduce the Harvard-MIT Belgian Society. So the Harvard-MIT Belgian Society is founded by Belgian fellows within Harvard and MIT in support of Belgian-minded academics and professionals. We aid in a soft landing of incoming talent in Boston and aid them in developing a social and professional network. We intend to help connecting Belgian-minded fellows with each other and entities inside and outside Boston. Besides social and networking events, we also organize scientific events highlighting transformative and Belgian endeavors and collaborations at Harvard and MIT, with intent to increase the connection with Belgium, Belgians, and these fantastic Bostonian institutes. For more information on the Harvard-MIT Belgian Society, please check out our website, www.harvardmitbelgiansociety.org. For tonight's webinar, it's focused on past and current responses against COVID-19, and we're truly grateful to Professor Nele Brusselaers and Professor David Walt for accepting our invitation. After the talk of each speaker, there will be an opportunity to ask some questions specifically related to the talk by using the chat function and send them to either Frederik Akke or myself. At the end of the talk of Nele and David, we will open it up to more general questions. And after the talk, we will enable participants' microphone if people would like to interact after the talk. Frederik will now introduce our first speaker, Professor Nele Brusselaers, and her talk on an epidemiological comparison of COVID-19 responses of Belgium, Sweden, and the USA. Please, Frederik.
Thank you. Good evening, everyone. I would also like to welcome you from my part on this webinar around COVID-19. It's my pleasure to introduce the first speaker. Epidemiologists have never been so popular, so we are happy that Nele Brusselaers is able to explain to us this pandemic from an epidemiological point of view. She's a Belgian MD PhD trained at Ghent University. Subsequently, she did additional trainings and a postdoc both in Belgium and in Sweden, where she became an associate professor of clinical epidemiology at the Karolinska Institute. Only recently, she came back to Belgium, combining her position in Sweden with a professorship at Antwerp University in the vaccine trial team and infectious diseases epidemiology and diagnostics. Consequently, I think she's perfectly positioned to compare the COVID-19 situation of three particular countries of interest: Belgium, Sweden, and the US. As said, you can send Cornel or me questions for her in the Zoom chat function, which we'll summarize and ask her afterwards. Professor Brusselaers, the floor is yours.
Yes, good. Good evening, everyone. Thank you very much for inviting me this evening and for introducing me, Frederik and Cornel. So yes, why am I here? I'm just gonna see if the slides work. Yes. So I'm a medical doctor and I have indeed done my PhD in Belgium. I also have a master in infection control and hospital hygiene, and I'm trained as an epidemiologist in London quite a few years ago. And I'm still, as Frederik said, working at Karolinska Institute, combined with a position at Global Health Institute. In Karolinska, I work actually in the Center for Translational Microbiome Research. So somehow I do like bugs. Also, in my daily research, my ordinary research, I'm usually looking at microbes and the effect on health, basically. And I actually also want to say that I'm also part of the Scientific Forum, which is a group of scientists. I think we're now with like 45 people, scientists from Sweden or related to Sweden, who are basically aiming for a transparent and evidence-based approach of the COVID pandemic in Sweden. We all are volunteers, basically, and we do our best to inform the public and actually also have an impact on the policy. So yes, this is a screenshot of today. It has been a while since I looked at this website. The numbers still look terrible. They already looked terrible a couple of months ago during spring. So now we are over 40 million COVID infections confirmed and over 1.1 million deaths, recorded deaths. I will show you quite some graphs and numbers today. So of course, I will try to guide you through, because it's not that easy to just see the numbers and see the whole picture. So like this one, it's based on the recorded numbers. So of course, if you're not diagnosed, you will not end up there. So I first want to actually start about this with the starting position of the three countries. So indeed, we have Belgium, Sweden, and the States. Okay, they're all doing, they're all not the best of the class for the moment. So if you just look at the baseline position and some baseline characteristics, well, everyone knows the maps, but just to see, I just used the Google Maps to show, first of all, Belgium, everyone knows it. But if you see how dense this country is, how close the roads are, how many highways, then we see Sweden, almost entirely forest. So you see my Google Maps still knows that I've been living in Stockholm until, recently, until this summer. So Stockholm is here, but you see very green, not that many highways going through, and then we have the US. If we put this in numbers, Belgium and Sweden are approximately the same amount of inhabitants, so around 10, 11 million. And yeah, US is of course bigger with 308 million. But if you look at the population density, well, we're almost with 400 people per square kilometer in Belgium, compared to Sweden with only 25, or the US 33. So there's, in Belgium, we all live like sardines, basically, compared to those other countries. I also wanted to point out that in Belgium, we actually have 4 neighboring countries, not counting the UK because there's a sea in between, but the Netherlands, France, Germany, and Luxembourg. And there are no clear geographic borders or even frontiers. So, you know, I don't think there are many Belgians who never went abroad, because, you know, the country is so small and it just doesn't take any time to cross the border. So it's for me quite a change again to be in Belgium, where everything is just like maximum an hour drive, basically. So compared to Sweden, Sweden is only bordering with Norway and with Finland, and mostly surrounded with sea. The US is only bordering geographically with Canada and Mexico. All the 3 countries, they have similar human development indexes. So they're all highly developed countries, among the best in the world, all in the top 20. What is interesting for this pandemic is actually also to look at the number of hospital beds, because it's a way to see how well our countries are basically prepared if something happens. And then you see actually that Belgium is not doing that bad. Belgium likes a lot of hospitals, and basically you have 3 or 4 hospitals in every city. So it's never very far away to get to a hospital. So the number of beds and also the number of intensive care beds is way higher in Belgium than in Sweden. But I guess Sweden and the US are quite similar in that aspect. It already looks, quite a lifetime ago when the COVID pandemic was starting. So here I also just put the first dates when the first cases were diagnosed or confirmed. That was January, February. Actually in Belgium, 4th of February, and the first one was actually in the US, if you put those 3 dates together. It doesn't mean that it was then that the first person really had COVID, because we now also know that many people could have been presenting with COVID symptoms several months before. And the deaths started rising in March. It was approximately mid-March that the WHO declared the COVID outbreak as a pandemic. And that's when in Europe, most countries went into a lockdown, and that suddenly all the flights were canceled going to the US, and basically everyone's life was upside down. I guess for most of us, it was quite a shock Also, we could have seen it coming with China and especially Italy, but then, yes, then it was suddenly all happening. So also to just start about the baseline position. So this is just to have an idea of how many people travel. So in the US, there are 800 million people flying into the States every year. That's in 2015, so that's 5 years ago, so it's probably already higher. The incoming flights in Sweden and Belgium are quite similar. But then if you compare Sweden with Belgium, Belgium has a lot of road traffic as well, a lot of traffic, both persons traveling and also commercial traveling, driving through. So even if you see that Belgium is that little yellow dot here on the map, you see that the incoming international travel is higher in the neighboring countries. So Belgium is having more international traffic than the Nordic countries. So how are they doing? This is the graph from our world in data. So what we've seen here, this is the daily number of confirmed cases. So in the US, it actually went up quite fast, and then it basically plateaued a bit, went up again, and then it remained high the whole time. The Belgian one, this is the peak in spring. Then it went down, then it went up again. They tried to slow down a little bit again, went up again, and now it's again going up, and hopefully they're able to bend the curve again with the stricter restrictions which have been introduced quite recently. So, and Sweden is here, so you see everything happened slower than the US, slower than Belgium, slower than many other countries, but the numbers were going up as well. They lasted high over summer. So over summer, it was actually one of the highest infections per capita in Europe in Sweden. And then it went down because the Swedes, they all take very long holidays. They all go on holidays for 3 to 5 weeks. So you really see, you basically had a natural lockdown. And then the numbers went down, and now the last couple of weeks are going up again. So you also see that there is here the gray line, very little information about testing in Sweden, while the other countries have a bit more clear information about that. So how is it with the deaths? So here we have again US, it's a total number of deaths. So it's quite interesting to put it in perspective. So indeed, Belgium is not doing that well. I want to point out here in Sweden, one of the issues that me and several of my colleagues have had some issues with is that the reporting of the deaths has been really slow in Sweden, and there were delays for up to 5 weeks to report the daily deaths. In Belgium, they actually had a system up and running from January already to have all the deaths reported daily, before 11 o'clock, or the hospitals would be slapped on the fingers. So in Belgium, there was a very good system reporting nationwide up and running for deaths in January and March for all the hospitalizations. While in Sweden, there's still huge delays in reporting. So it always seems that the infections and the deaths are going down, but it's just a delay in reporting. So which numbers are actually very important, and how do you interpret them? Yeah, we all look at the number of infected individuals, the mortality, of course, the number of people in the hospitals, at the intensive care units, also excess mortality, and also what's also important that people tend to forget is how many people actually test positive when they're tested. So it's important to know that some countries count confirmed and suspected cases. If there's large-scale testing, it has been recommended by WHO since spring to really test as broadly as possible, if the capacity is, of course, available, because that has to be scaled up. Most countries didn't have huge testing facilities beforehand because they didn't need it, or so many research institutes basically redid their whole hospital or whole testing lab to become COVID testing. And that's also what happened to the lab where I'm part of in Stockholm. So the criteria of who is allowed to be admitted to the hospital or to the ICU, there are also differences. The delays in reporting already said. So it's the numbers you always have to take with a grain of salt, because it's dependent on the policy, the capacity, and most of all also reporting. So Worldometer, all 3 countries which are now on the program today are in the top 15 of worst countries, considering the COVID pandemic. If you look at the number of deaths per capita, so per million of inhabitants, Peru is actually now taking the lead, unfortunately, with more than 1,000 deaths per million. Belgium is taking 2nd place, but then you see USA, the US and Sweden are kind of similar, around 600, 700 cases per million. Interesting to see is as well, Belgium and US are doing a similar amount of testing, while Sweden is not testing as broadly as in the other countries. I will come back to that. So, of course, I didn't count the countries with, the very tiny countries with not that many people, because otherwise it would have been a bit of a distortion. So what I wanted to say as well is, if you test more, you will have a lower case fatality rate. And if you also would count suspected tests, then you will have, of course, a higher case fatality rate. So if you see here, like in Mexico, they reported basically 10% deaths. So 10% of all those diagnosed died, while in the US it was around 2.5%. If you look at the WHO numbers, they say that from the reported cases, on average globally, 3 to 4% dies, but that's not the same of everyone being infected. Those estimates are around 0.5% if a healthcare capacity is sufficient, so if healthcare can be provided. But of course, the real number is difficult to estimate. Early in the pandemic, around February, March, people thought it was higher because, of course, they didn't know that there were so many asymptomatic and pre-symptomatic people as well. If you see for seasonal influenza, it's only 1.1% mortality, so it's without doubt for the corona infection is more lethal than influenza. So as I said, you could look at confirmed case and probable cases. WHO definitions and from the European Center for Disease Control, they actually recommend for surveillance purposes to look at both. If you look again in Belgium, so that's the Cienzano is the agency looking at the Belgian numbers, they still include probable cases for the deaths, the deceased in the elderly homes. In Sweden, they've only been looking at confirmed cases, and over time, they still have not been testing as broadly as in other countries. So if you want to look at mortality, you actually have to look at the excess mortality. So how many people died in comparison to the previous years? And that's what you see here for the US. So you see that every year around the wintertime, there is a peak. In wintertime, more people die. Usually it's influenza or other viruses because people just get more sick in the winter. And here we have the corona outbreak. So you see that there's a clear increase compared to the normal situation. So basically, if it's above the orange line, it's excess mortality. So, and here we see it for both Belgium and Sweden. So what we see in Belgium, it was quite a high peak, then it went down. For Sweden, it went up and it went down very, very slowly. And here still over summer, it was very close to the excess risk as well. And here again, as I said, for Sweden, you see the numbers going down over the last few weeks, the late reporting, while in Belgium, there is not such a problem. So these numbers are quite accurate. So what actually does that excess mortality mean? If we look at the graph for Belgium again, for this April, that's here, that's a peak in April. And then they basically had 600 deaths per day, while they would only expect around 300 if you would look at the numbers per day, per season as well, based on the previous years. So you again seen fluctuations every year with the seasons. This is actually how the excess mortality looks now. So we know that we're testing more. So we're detecting more COVID cases than in spring because the testing capacity is increased everywhere. This is April, so you really see clear excess mortality basically all over Europe. And now we don't have big excess mortality yet. We don't know how it's going to evolve the next couple of weeks. There are more infections, there are more hospitalizations, but we also know that the people are less sick in many places. So hopefully the excess mortality will not reach the same level as during spring. So yes, everyone has seen those curves of flatten the curve and slam it with a hammer. So why do we do that? Oh, I'm happy. I thought the animation wouldn't work, but we don't want our healthcare systems to collapse. We see it in many countries that, you know, all our doctors, all our nurses have worked really hard to, you know, treat all the patients, reorganize the hospitals to care for all those people, and we don't want to risk that our hospitals can't cope with the number of patients, and because then also normal care, the standard care, is delayed. People with cancer will be diagnosed later. Surgery will have to be postponed as well. So I think it's really important to have a functioning healthcare system. So if we go to the next one, these are some predictions. I've also been involved in prediction models for Sweden. It's really difficult to predict because there are so many factors playing a role. Some of those are social distancing, and that's not always as easy to take into account or measure how the level is. But so this one, so here is today. So you see that the number of infections went up, went down, and they actually give projections for if the current recommendations are followed. That's that brownish line. If the current recommendations are eased, basically, then it's quite similar, because in Sweden there are still no real recommendation, or there are recommendations but there are no restrictions. So there are no laws, there are no fines if you don't do social distancing. If you would introduce masks, the infections will go down. Quite a big difference. If we go to Belgium, we are here. The projections are, with the current restrictions, that it will go up a bit more for quite a few weeks and then level off. If everyone would be wearing masks, the level is higher. If they would now just abandon all the restrictions, well, this is quite an impressive peak. And that's what earlier models that I've seen months ago already said. A second peak can be worse than the first one. This is the first one. So quite a drastic difference. So it's really important that we follow regulations. This is for the US. The US is a little bit, it's again another curve, but you know, reality can catch up with us, and so probably none of those lines will be exactly predicting what will happen. So in the US, it's also predicted that the numbers will go up, go down quite drastically with the masks, and if you would just abandon everything, also a huge increase. So yes, everyone has seen those signs. Keep your distance. If you are far enough, you should reduce the risk. Unfortunately, there is also an aerogenous spread of the infection. So it's not only through droplets, it's not only through contact, it could be infectious through the air as well. So one of the measures which has been advocated early as well, not besides the lockdowns, because lockdowns are done when you really can't control it. And there are also different definitions for lockdown. But one of the things which is recommended is that you test, you trace, and you isolate. If you only test, but you don't put people in quarantine, it's basically no point. They only recently introduced that in Sweden, that the family members and the person himself or herself have to go in quarantine. They still don't put children in quarantine. So they basically have been testing, but the recommendations for family quarantine have been a bit so it's three things: testing, tracing, isolation. You can't do one without doing the others. And it also, if you trace, you can also see if there are super spreader events. So which countries are doing tracing? Both the US, Belgium, many countries are doing tracing. In Sweden, it's the responsibility of the people who are sick. So if you're in ICU, you are responsible for the contact tracing. So masks, another thing which is recommended. So here we see the mask use. I actually don't know how they estimated it, but apparently in Belgium it's around 70%, quite similar in the US. And of course, they hope that more people will start using them. If we look at Sweden again, so I hope, I'm trying to not be too critical, but you see the mask use is still basically absent. You're still a very big exception if you wear mouth masks, because the health authorities basically keep saying that they don't work. And that's interpreted by many authorities that, or other agencies or companies, that, oh, we shouldn't use masks. So even in healthcare, even in hospitals, people do not wear masks still. And there are even people, reprimanded or fired if they wear mouth masks in hospitals, which I think is completely unacceptable. So this is a map. Okay, it's getting a little bit old, but it's from September, I think. So some of those red countries have introduced masks, at least at certain places, but you still see Sweden doesn't recommend any masks anywhere. And there are a few other countries, but most countries globally are using mouth masks, as the scientific evidence also shows that it can help to reduce the spread, and especially the speed of the spreading of the pandemic. So yes, I guess many people are also thinking about herd immunity. So in Sweden, they've always been circling around it. So compared to many countries like Belgium and Central Europe and several states in the US, they've never done a lockdown. They never closed restaurants, but then you shouldn't forget that many people have been isolating voluntarily. So many people who are older and vulnerable have basically been in isolation since March, the whole time. So these are some numbers. It's a map from in May when they did some immunity testing. New York, we all know New York was hit very hard, London as well. But you still see that the percentages of people testing, having immunity against COVID is still very low. For Stockholm, it's only estimated to be 10-15%. We also know that 1 in 5 loses immunity already within a couple of months, and also that actually second infection can be worse. So, and other strong arguments against herd immunity is that there has been no single infection for which herd immunity has been achieved without having a vaccine. So, and I think it's also very scary to know that even if you have been infected, that the infection the second time can be worse. So where does the term come from? This is a cartoon which I have been using, and it originates from vaccine trials. But then many people have been advocating it in the US, in the Netherlands, in Sweden, although not always as open, because there are quite heavy ethical concerns. But it's basically what it means. It comes from, if you have a herd of cattle or people and you would let the disease pass through, well, you will not reach herd immunity without having thousands of deaths if you look at the entire population. So I think the modeling for the pandemic, to explain it, is not that difficult, because we estimate, or the most recent estimates, that approximately 0.5% of those infected with COVID die. Okay, it's not that high, but if you would get 10 million people infected, you're already at 50,000 deaths. And this does not take into account people who can be reinfected. Okay, there might be people, if they are exposed to the virus, will not get sick. But still, the numbers are high. So even if you would say, like in a country like Belgium or Sweden, that half of the population would be protected somehow from this infection, it's still a very high cost. And besides the deaths, although they're easy to measure, we should also not forget that that there are also people, the long haulers, they call it, chronic symptoms. And in some cohorts, it's even like 75% of people who had COVID who have organ damage. We don't know how long it will last. Some of those affected might have symptoms for several months or even years afterwards. We also know that there are huge impacts of this pandemic on everyone's life. We all want to get rid of it, but then if you let the infection spread around a society, it has a huge impact on the economy, also on our and psychological well-being. So these are all factors that you have to take into account when deciding on policy. So yes, I advocate basically evidence-based decision-making in this pandemic, and good and clear, transparent reporting of data, looking at the different angles. So now I'm actually done with my talk. I think I'm approximately in my time. And yes, we all want to get rid of this, but yeah, humans are living on this planet and have a big impact. So it's quite likely that there will be another pandemic coming around, maybe not in our lifetimes, hopefully not in our lifetimes. But yes, we have to take care of our planet, basically. So yes, that's it basically. Thank you for listening. I hope I can keep talking for another couple of hours and days, but yes, thank you.
Thank you, Professor Brusselaers, for your excellent talk. We have collected some questions to you, which I will ask you right now. Yes. Are there initiatives to standardize number reporting among different countries? And if not, which estimators would you suggest?
Well, I know that the WHO and especially also the ECDC are advocating clear reporting, but then it's very difficult to have a standardized approach. Also, they have to have an approach which works. So yes, I think the number of infections is really important, because you have to know how widely spread it is, but then you also have to test. So if you don't test, the number of infections is very vague. Excess mortality you also have to keep an eye on, but then the problem is that it's you only know it after a couple of weeks, reliable for most countries. So number of hospitalizations is something which you need to monitor from a policy perspective, because you need to know how long your hospitals will keep coping. And that's something that's really important, of course, because hospitals need to be reorganized and be prepared for an influx of patients. So yes, as much data as possible, and as fast and as transparent as possible, I would say.
Okay, thank you. The second question is, besides masks and lockdowns, are there alternate policies between the US, Belgium, and Sweden affecting the spread of COVID?
Well, what we see in the US is also that it's very state dependent. So there are also local restrictions, and that's now something that they're finally considering in Sweden as well, that that you could have local lockdowns or limitations. One big thing is also the banning of the events. That's like I know in March, I thought it was also a bit Kafkaesque that like in Germany, every gathering of more than 2 or 3 people was banned. While in Sweden, then they banned everything above 500, but now in Sweden it's currently at 50, and I heard rumors that they will reduce it as well. So because we also know that many of the infections are actually, not everyone is infecting as many people. So most people only, on average you infect 2-3 people, but some people do infect 30, 40, or even more people, while other people may not infect anyone. So I think you really, one of the things is that you really have to try to trace the super spreader events and prevent those if you want to get the numbers under control.
And the third question, which is a little bit related to this, do you think that a division into states such as in the US or into smaller regions could be beneficial in order to stop the spread?
Well, if the states take the lead and really take action, it's a good thing. If there is just chaos and conflicting instructions, and if people don't understand the rules and the regulations, it will be very difficult. I think that's one of the problems in Belgium as well. It's not the most, there are also so many different people involved, so it's very difficult to have a nationwide and fast approach. But then if you see in Sweden, yeah, they have like nationwide instructions, but then they're not enforced and nobody really takes charge. And then the regions are all just saying like, okay, but it's, so it's anything that works on a quick and efficient level should, would be better. And that's what we've seen in many Asian countries, that they acted quickly and organized, implemented measures, and people have adhered to them as well. Which is, so it's very cultural specific as well, to see how people react to advice. And that's something we've seen in all 3 countries and a bit everywhere.
Perfect, thank you. That's it for the specific questions on your presentation. Good. So I think we can move on with the remainder of the webinar.
Cool, thank you.
Hello, everyone. Thank you, Nele, for this wonderful talk. I gladly introduce our next speaker, David Walt. So David is a member of the faculty at Harvard Wyss Institute and the Harvard Medical School in the Department of Pathology at the Brigham and Women's Hospital. And he is also a Howard Hughes Medical Institute professor. Previously, he was a university professor of neuroscience and oral medicine at Tufts University. He is scientific founder of the Illumina Incorporated and Quantarex Corporation and has co-founded several other life science startups. During the Corona lockdown, David emerged as one of the leaders at the newly founded MGB Center of COVID Innovation. And David has since then, either through the MGB Center of COVID Innovation or either in his own lab, been at the front lines in finding solutions and setting up strategies to implement key innovation in the clinic as soon as possible. Thank you very much, David, for accepting our invitation to share your experiments on current COVID innovations and strategies. David, the floor is all yours. Thank you so much.
Thank you, Cornel. And Nele, that was an excellent presentation. And I'm impressed with how well you could do, considering it's the middle of the night there. So feel free to take a nap during my talk if you need to.
Thanks.
So
I look forward to hearing your talk, actually.
So Nele, you did a great job setting up my talk, and some of the slides will overlap, and I'll just skip over those. But really, what I was hoping to do tonight was to talk about some of the lessons that we've learned from COVID-19, and also perhaps give you some lessons that I think might help us prepare for future pandemics. And at the end, Cornel's asked me to speak a little bit about the MGB Center and what we're doing here in Boston. And actually, as part of my talk, I'll show many examples of things that have been innovated at the MGB Center for COVID Innovation. So let's go back a little bit to some of the fundamentals. We know that it spreads between individuals, that there's a wide variety of severities of illness. And right now, while there are some therapies that are becoming available, none of them are curative, and we don't have vaccines yet. The virus itself has a very simple structure. It has these spike proteins that give rise to the name coronavirus, like a crown. And then inside the protein shell of the virus, there is the genetic material. And in the case of SARS-CoV-2, which is the virus, this genetic material, unlike that of humans, is RNA instead of DNA. And Nele showed you this slide earlier, but she must have taken the numbers a little bit later than I did. I took them just early this afternoon. And so even just today, there were many more cases, another 150,000 cases added to this number based on what Nele showed. And there were, again, thousands more deaths. So this is really with us right now. it's important to understand that coronaviruses have been around for a few decades. They've been around a long time, causing the common cold, but pandemic or epidemic versions of coronavirus have appeared early in this century. The first SARS event occurred in China in 2002 and 2003. There were 8,000, a little over 8,000 cases, 700 deaths. So that's a mortality rate of 10%. The R0, that means how many people it is able to be transmitted, how many people get infected per infected individual. That is the transmissivity factor, is between 2 and 4 people get infected for each person that is infected. MERS, many fewer cases, but much higher mortality, 35% mortality rate, but the transmission rate was much lower, and that's why, fortunately, this did not have the sort of pandemic potential that COVID-19 does. You see here, this was obviously just updated a few days ago, but we're close to 40 million cases. Globally, 1.2 million deaths, and that corresponds to mortality rate of between 2 and 2.5%. And I know Nele talked about around half a percent, but of course now that's where things are now that we have a little bit better understanding of how to take care of individuals. And the transmission factor, the R0 is between 2 and 2.5. That is, 2 people get infected for every person that is infected. And the scary thing here is that if we now think about putting numbers like this, combining them with the mortality of MERS, you now would have in this case, many more than 10 million deaths globally. So we have to be careful, not just with this particular pandemic, but there's obviously future possibility that we could have a much worse one if we end up with mortality rates that are similar to the MERS. So Nele mentioned aerosols. This just shows you the incredible dispersion of aerosols from breath. And this is why face masks work. They really diminish it somewhere, on the order of about 70% of the aerosols can be contained by just simple fabric face masks. And so this is really a prudent way to go. The symptoms are highly variable. This is a respiratory disease first and foremost, so people have difficulty breathing. That's why it infects the lungs, and that's oftentimes the symptoms, but it really manifests with many different kinds of symptoms. There can be gastrointestinal, neurological effects of the disease, and this is just a consequence of the fact that the receptors are prevalent in many different cell types and organs in the human body. There was a question about face masks, but these are the CDC's most recent guidelines: washing hands, avoiding close contact, covering your mouth, using a mask, covering coughs and sneezes, continuing to clean and disinfect surfaces, and then just being self-aware of what your health is on a daily basis. And if there's any indication that you have some symptoms that I showed on the previous slides, don't go anywhere, because you have the potential to go and infect individuals, and it's often at the earliest stages of infection that you're the most infectious. So it's rather remarkable that in December in Wuhan, China, the first case of a pneumonia-like disease was discovered, and literally 6 weeks later, within a few weeks, the RNA sequence was known, the virus sequence, genetic sequence was known, and 6 weeks later it was published in the New England Journal of Medicine. But that is an absolute astounding achievement for technology, because we have the ability now to identify the causative organism in a matter of days to weeks, which is unprecedented. When the first SARS event occurred just 20 years ago, it took months to come up with the viral sequence. And if it had happened 10 years before that, it would have taken probably 6 months to a year to determine the virus sequence, just because of the advances in sequencing technology that have transpired over the last few decades, including portable sequencers that can be taken directly into the field. And some of these are actually being used and deployed for diagnostic testing right now. This is actually the way that the Mass General Brigham Center for COVID Innovation is organized around these 4 different areas: devices, diagnostics, therapeutics, and data analytics. I'm going to take you through all 4 of them and try to give you some appreciation of the incredible efforts that have been made in trying to address these 4 areas for this particular pandemic, but also to provide you with some lessons about what we've learned and perhaps some things we should avoid in the future. So with devices, this is just a small sampling of the kinds of devices that were needed. And I'll take you through a number of these. So one of the first things that happened, at least in the healthcare system, particularly here in Boston, early days, was just a shortage of face masks and a shortage of face shields and N95 masks that are used for really protecting healthcare workers. What you can see is that there have been innovations in things like face masks, because healthcare workers, if they're covered, their faces are covered, and you're a patient, you can't see your healthcare worker smiling. You're already not in a good mood, but we recognize that this human interaction, this human interface of smiles and being able to see people talk was something that was a real important psychological aspect of face masks. And so again, innovations where they still provide protection, and they still allow perfectly comfortable breathing, but they enable the wearer to show their full face. And so I'm going to show you now, I hope this plays and you can hear it, but one of the first things that we needed to do was to apply a new technology to the production of face masks. And this is just a minute long.
At Azul 3D, our mission is to move 3D printing from prototyping to manufacturing. When COVID-19 spread across the world, PPE shortages put healthcare workers at risk. It quickly became apparent that 3D printing could rapidly respond to the shifting needs as the crisis developed. Traditional manufacturing remained bogged down by a broken global supply chain. We joined others in the 3D printing community. Within 48 hours, our first prototype printer was manufacturing face shields at a rate of 1,000 units per day. Enabled by Azul's proprietary HARP technology, this printer has removed the manufacturing bottlenecks that have held back additive manufacturing. We set out to produce 10,000 face shields, donating them to healthcare workers and first responders across the country. One printer, 250 print hours, 10,000 face shields.
So you can see that, again, innovation and technology, this was not available 10 years ago. I think you all were aware of 3D printing 10 years ago, but it was really just to make little toys. And now we have the capacity in a matter of days to create tens of thousands of devices that can be used and deployed in real time while the supply chain is adjusting. So another need that arose was really the face masks that were being used, they were being used at such a rapid rate that the supply could not keep up with them. And so there were efforts both in the commercial sector with Patel and also at Mass General to produce decontamination systems that could allow these masks to be adequately sterilized so that they could be reused, and they did not compromise the ability of the wearer to breathe. So again, incredible innovation just spun up within a matter of weeks. Full body protection. People were donning gowns every time they wanted to take a sample to do a diagnostic test. They would have to change their gown, change their masks. And so there was innovation in terms of being able to produce these much more sturdy, robust kinds of systems that protected the healthcare worker, protected the individual subject who was getting tested or being treated without having the need to continually change and waste all these sterile gowns. There were patient isolation hoods that were deployed so that operations that were generating aerosols would protect the healthcare workers, isolate the patient from the healthcare workers, but still allow the healthcare workers to work and operate in the same kind of theater, surgical theater kind of environment that they were used to. And many other devices. There were 3D printed nasal swabs. There were ventilators that were developed that repurposed existing instruments just because of the incredible shortage of ventilators. I'm sure those of you who were here back in March know that all the hospitals were just completely filled, and there were ventilator shortages. So they were repurposing all sorts of instruments to really address the need. And then, other kinds of things that came about. We talked about sort of the psychological needs of patients. Patients were isolated from their families, and this was a hydraulically actuated virtual hug shirt that family members or members of the healthcare staff could actuate and actually give the patient a virtual hug that just helped them keep their attitude high. So with devices, we had rapid prototyping and scaling using this additive manufacturing, formerly called 3D printing. We also learned that even though the supply chain is global, when countries need supplies for their own use, they use them. And in fact, in the US here, we really suffered from a supply chain that was primarily provided by Asia. They provided many of the respirators, many of the face masks, much of the PPE, and they had to use it for their own population. And so the supply really was cut off for us for a period of time. So we now know that we need to stock these critical supplies well in advance. Let me talk a little bit about diagnostics. Again, there's sort of three different things that we can test for. We can test for the RNA, that's the viral RNA, this yellow structure in the middle here. We can test for the proteins, primarily the presence of the spike protein that indicates that the virus is present. And then we can also test for something called antibodies, which are the response that we humans have, our immune system have to produce and fight off the virus. And I'm not going to spend a lot of time on this, but the important thing is that here we have RNA. So this is the presence of RNA right here, and it lasts for weeks, whereas antigen comes and goes. That's the viral protein. And then the antibodies begin to kick in, and as the antibodies kick in, the virus disappears, or that's the hope. And so we've all heard of the nasopharyngeal swabs. These are the swabs that go very far back in the nasal cavity. People say that it sort of tickles your brain. Those are the conventional ones that are used mostly for the molecular tests that measure the viral RNA. There's a new kind of swab called an anterior swab that doesn't go as far into the nasal cavity, more comfortable, appears to be about as effective as these previous swabs. And then there's now a lot of effort being made to use saliva as the sample because it's easy to collect. Individuals can collect it in their homes, either mail it into a laboratory or self-test. And then there's blood, and we'll talk a little bit about that in a minute. The places where testing is performed are in these three locales. The first is in central labs. Most of the testing of the PCR tests are done in central labs. There's a trend now to move the testing to point of care type of facilities, such as urgent care centers, local pharmacies. And then there's the direct to consumer. Can we begin to get tests that we can use in our own homes? The molecular tests are run in central labs. This is a picture of the Broad Institute. They can run nearly 30,000 tests per day. There's a lot of people that have to do the sample prep, but they also do a lot of work with robotics at the Broad. So that's really the workhorse for the Boston area. Most of the universities are sending their samples there. In fact, Mass General and Brigham are sending most of their patient samples there with a roughly 24-hour turnaround time. The antibody tests are really not a diagnostic test. They're to look to see who has been previously exposed, and they can be used to look for the community prevalence. We heard previously about how many people in a population have been exposed. That's done by testing how many people have actually developed antibodies against the virus, and that of course eventually will be what's important for the herd immunity that we heard earlier. It also, these antibody tests are being used in clinical trials to look at vaccine efficacy. That is, when you get a vaccine, you're supposed to develop antibodies that recapitulate the response of a natural infection. And so if you develop antibodies that can bind to and eliminate the viral proteins, presumably that is indicative that you are immune protected. And then there's now a burgeoning field of these antigen tests, which unlike the PCR tests that have to be run in central labs, tend to be able to be run either at point of care facilities like urgent care centers or doctor's offices, or maybe even eventually in your own home. They're cheap. They're on the order of $5 to $10. They take 15 to 30 minutes to run. And so you get much more rapid results. The challenge with these is that they're not as accurate. They have a tendency not to pick up infection as sensitively as early as the PCR test. And so they can give some false negative results as a consequence of that. There's other kinds of testing that are beginning to be used. For example, the next generation sequencing instruments can literally run 10,000 samples at a time for individuals. The problem with this is that it's only cost effective when you have something on the order of 2,000 samples to test. And so some of the central labs like the Broad Institute are considering moving to technologies like this because they're cheaper and you could do many more samples at a time, even with a single instrument. And then there are now studies to monitor communities. This is not really a diagnostic test, but it looks for RNA in the wastewater coming out of wastewater treatment plants. You can actually measure the RNA that's present, and that correlates with the prevalence in the community. And so I think as we get further down the road in eliminating the pandemic, what will be useful will be to use these kinds of technologies to do massive sort of community-wide testing to look for hotspots. And that, I think, will be the real use of these kinds of technologies. So, what went wrong with testing? I think, there's a number of issues here. I'll highlight just a few of them. There were way too many companies that got into the testing business that were distractions. The validation was not rigorous. These were self-validated tests, and so obviously, as they're rushing to try to get these things to market, they're cutting corners. The approval process from the FDA was quite rapid, and also, you know, the companies that really have the capacity to scale testing to tens of millions or hundreds of millions of tests, those companies just didn't say anything until they were ready to launch, and they finally did. But you know, it was only recently, and so it created a whole mess in the industry as a consequence of all these small companies trying to get products to market. I think we're now in a more stable mode where companies like Abbott and Roche and Becton Dickinson are now going to be able to produce hundreds of millions of tests per month that will, eventually early next year get us into the mode where we'll be able to test people at scale for reasonable cost. A few other things. I think the idea of trying to run all the tests in a central laboratory is okay if you're a central government like China, but in the U.S. where there's many companies and many communities, many different states, we really need to get the tests into the communities as opposed to trying to get the samples to the central laboratories. So therapeutics, let me go through a few of these. So repurposed drugs, the drugs that have been approved so far, for example, remdesivir and dexamethasone, those are two. Remdesivir is an antiviral agent. It was validated by a high throughput screen. Dexamethasone, same kind of thing, identified through a screen to be able to knock down the inflammatory response. There's not enough time to discover a new drug for COVID-19. You have to use something that's already approved, and that's what was done. Looking at the hundreds or thousands of drugs that have already been approved and are on the market, which ones could be deployed in a rapid time frame that could be used so that we could at least have some therapies available that could decrease the morbidity and mortality of the disease. You've heard about convalescent plasma. This is where a patient who is recovered now donates their blood plasma to a patient that's now infected with the virus, and the presumption is that the antibodies that the patient, the recovered patient develops can be used to now get rid of the active virus in those infected patients. There are no validated studies that have shown the effectiveness of convalescent plasma. Monoclonal antibodies, I would say we have an example where this seemed to work with the president a couple weeks ago, receiving monoclonal antibodies. These are antibodies that are synthetic. They're designed to bind to the viral proteins and prevent it from infecting, prevent the virus from infecting other cells. It seemed to work in his case. Again, these are undergoing clinical trials. The studies are blind right now, so nobody knows whether they work or do not work. The president may have gotten better spontaneously. So again, there's a lot of excitement about these, but what I could say is that the company that makes the monoclonal antibody Regeneron that the president got has the ability to make 50,000 doses. That's certainly not enough to treat everybody that becomes infected and manifests with symptoms. And so again, this is a stopgap measure only useful until we get vaccines, which I'm not going to really cover, but is aimed to again recapitulate an active infection either through introducing proteins in some way, the viral proteins to which the human immune response reacts, or in the case of the Moderna vaccine, they introduce RNA in the form of lipid particles that mimic the virus, deliver RNA, usurp the subject's protein translation machinery to convert RNA into protein. Those proteins then initiate the immune response, and that's the hope, is that those are going to generate a robust immune response and generate cells, memory cells, that will be able to recognize this upon future infection. But again, as we heard, in the earlier talk this evening, there's the possibility of reinfection, and vaccines, in some cases, in some individuals, can actually, if you're vaccinated and you get reinfected with the virus, could cause an enhancement of, and a more severe form of the disease than you would have if you just got initially infected. So I'm going to go through there. The lessons learned, we can rapidly discover drugs that are affected by repurposing existing drugs. Convalescent plasma, monoclonal antibodies, their effectiveness is still unclear, undergoing clinical trials right now. Vaccines can be rapidly developed, but still their safety remains an issue. And then in all these areas, we really ideally would like to run controlled blinded studies, but in the case of a pandemic, we don't have time, and there's an obvious need to compress the time frame for over the kinds of things that we normally would do. The last topic I just wanted to cover briefly is just the need for data and analytics, and it really goes in sort of three buckets. The first is using electronic patient data. So when we have patients in the hospital, using those data to be able to process those data and predict outcomes based on aggregating large data sets of lots of individuals, whose records of their heart rates and oxygen saturation and temperature and everything else. We also have the ability to continually monitor people, not for virus, but for some of the easy things to measure using wearable sensors. And then we already heard about the importance of digital contact tracing. And this is, I think this was covered earlier, but the important point is that these are done through Bluetooth types of contacts where phones come into proximity, and then they broadcast. And if somebody gets infected, one can then trace back all the interactions that were at a certain distance and a certain for a certain duration, to prevent those individuals from, or to let those individuals know that they should quarantine, get tested, because they have the potential to have been exposed to somebody that is infected. So deep collaboration across the board. This is what we do at Mass General Brigham in the Center for COVID Innovation. Clinicians, engineers, scientists, very deep collaborations. Many technologies have been invented, innovated, and rapidly deployed in a very short period of time. This is a global problem that requires global solutions. I think the examples we heard of Belgium, Sweden, and the U.S. I think we really need to sort of come together as a global community and address the problem, as opposed to doing this country by country. Again, it's not over. So in the last 2 minutes, I just wanted to spend a couple minutes talking about the Center for COVID Innovation that Cornel mentioned earlier. This was launched back in early March, as soon as the first few cases came into the Mass General Brigham system. I am co-director with Gary Tierney, who's at Mass General, and it's really to develop, do a rapid investigation and deployment into the clinic of devices, diagnostics, data and analytics, and therapeutics, all the things that I talked about this evening. And so we founded it on those 4 pillars of the system. And these are the key working group leaders. Gary leads the devices, I lead diagnostics, even though we're both co-directors. We each took one of these areas, and then we have other leaders in the therapeutics and analytics group. And we have huge community of volunteers and participants from almost every academic institution in Massachusetts, clinicians, we have companies involved, just people across the city and the state. And so, I spoke about many of these things. This is the devices working group. They deal with each of these things. They have 9 different groups, each working on a different area of devices. In diagnostics, we are working. We've actually set up a laboratory called the Accelerator that is there to evaluate and validate different diagnostic technologies independently, as opposed to relying on the companies. And then we have a Horizons technology group that's looking, what's going to be the next technology that's going to really help us get out of this 6 months or 12 months from now. And then we have some implementation strategies. So here's a picture of the Accelerator. This is the lab that's set up to test these. And then we also have, as I mentioned, an implementation group that's looking at global implementation. We have partners in 8 countries around the world that we're working with to deploy some of these technologies and help them out with some of the problems that they're encountering in their communities that are very different from what we have here in Boston. The healthcare workers, the doctors' offices, dentists' offices, community nursing homes, homeless shelters, and then really also studying large-scale populations with epidemiology, data analytics, looking at digital health, contact tracing, all the things that we talked about earlier, and then finally in the therapeutics area, really helping coordinate some of the clinical trials that are going on with not only small molecules and vaccines, but some of the immune modulators and some of the monoclonal antibodies that we talked about as well. And then provide support for those in terms of the design of those studies, how they're conducted, and then obviously that feeds back into the data analytics because there's huge amounts of data that are being developed. So if you want to learn more about the Mass General Brigham Center for COVID Innovation, you can go to this website. Happy to answer any questions, and it was delightful to be able to speak with you this evening.
Thank you so much, David, for your talk. We do have several questions, so just a message for everybody: feel free to shoot us any questions related to the talk of David and any more general questions for after that. So one of the first questions that we had is one of our participants asked your opinion about that virus propagate exponentially and treatments are easily overwhelmed by the viral load and affected cell. Do you think the curative treatments have a potential to combat future viral-induced pandemics, or will we always be restricted to preventive vaccine-based technologies? So a little more information about that is that most mentioned drugs in the talk need to be initiated soon or right after any symptoms before the onset to confer into benefits.
It's a great question. I think one of the things that is at least somewhat mitigating. I have 2 answers to that. One is biological, and And that has to do with the fact that the immune system is also exponential. You know, our immune system is geared to, you know, once our B cells and our T cells come up with the formula, they're designed to replicate as well. And so, you know, while the virus can do that quickly, you know, every cell produces millions of molecules of antibodies. And so, you know, when you do exponential on exponential, then you know, the immune system eventually can win for people who are immune competent. I think there's actually a sort of a missing piece here, and I think Nele might want to comment on this as well. But you know, the diagnostics, the therapeutics, the devices, the contact tracing, all that are tools that we can use. But you know, the biggest tool is to avoid transmitting the virus in the first place. If we had had the discipline to shut down our foreign travel, our borders at the beginning of the pandemic, it would not have become a pandemic because it would have been confined to China. And so, you know, we have to use all the tools that we have to be able to buy us time to, you know, to really, and there's nothing that I think we're going to be able to do to, I mean, yeah, we might be able to accelerate vaccines a little bit more, but, you know, safety is always going to be an issue. We may be able to accelerate the discovery of effective therapies, therapeutics a little bit faster, but again, safety and efficacy will still be a factor until you do the controlled trials. So Nele, maybe you want to weigh in on some of this.
Yeah, I was also going to say, yeah, organization-wide, if you see how rapid the numbers can go up, that's what we've seen the last couple of days as well in Belgium. You cannot cope with an influx of patients that rapidly. So you can't just let everyone get infected because you don't have beds, you don't have healthcare personnel. So it's indeed prevention, and you know, it's basically the start of epidemiology. Try to limit the spread of the infection, like they managed to do in several countries, also New Zealand, and yeah, the other Nordic countries besides Sweden.
Thank you so much. For the next question is from another David in the audience. It's regarding the testing. Should there be a systematic and weekly testing okay, for employees in larger institutes? Or isn't the actual policy going to be an issue during the winter, when every little cold will force employees to stay home until they get tested and the results get back?
Yeah, well, I think that, you know, one of the issues that we're facing right now in the U.S. is that the federal government has contracted with all the large diagnostic test manufacturers to purchase, you know, essentially 6 months of their supply. So, you know, Abbott sold 150 million tests, and BD sold, you know, 200 million tests. You know, those were purchased by the federal government and are being distributed to, you know, places like nursing homes and other locations, which is you know, perfectly fine and you know, is certainly consistent with the need. But if we could, you know, if you could go to your local pharmacy and buy a pack of 10 test strips for $5 each and test yourself every 3 days, even if it weren't perfectly accurate, we would catch most of the cases and be able to really, you know, clamp down on the transmission. Because, you know, if you test positive with one of these tests, you know, I mean, you still have to behave well. You have to stay home. You know, one of the things that we couldn't predict, and, you know, there was an article in the paper a few days ago, you know, saying the one thing we couldn't predict is that people that get positive tests will still go to a party and infect other people. There's nothing we can do about that unless we have some way of cataloging who gets tested, making sure that their result is input into some sort of electronic format, so that if they try to go outside of their home after a positive test, the police show up and escort them back home, or throw them in an isolation pod. So again, I think we have to use all the tools at our disposal.
Oh, thank you, David. We also received another interesting question: is does the rush on diagnostics and therapeutics, does that cause to skip any important steps in the validation, given these time issues? And how do you think, or how do you feel, how do regulatory organs such as FDA manage this?
Well, the FDA has I think let down the American public by approving things either too fast or without any evidence. They approved hydroxychloroquine because there was somebody in the White House that said that it was important to approve it. That was not based on science. That was just based on some anecdotal evidence. Remdesivir at least went through some level of testing, as did dexamethasone. To get specifically to the answer to the question, I think that the biggest concern I have, and I think Nele probably will agree with me, is in the area of vaccines. What most drugs, when you're talking about giving drugs to a target population, you're talking about a target population that will get that drug of maybe a few million people, right? It doesn't matter what drug, maybe a few million people. And so when you do a clinical trial with a few thousand people in that clinical trial in phase 3, well, you're gonna see the 0.1% of the side effects that might crop up. But when you're talking about giving 7 to 8 billion people each 2 doses of a vaccine to protect the globe, that's billions of individuals who will receive this. And even with 30,000 person trials, you're still not going to uncover a rare side effect that could be, it could be 1 in 10,000, it could be 1 in 100,000, but that means that a lot of people are still going to have that side effect when it gets scaled to billions of people. And so, that's the dilemma we're in. We're trying to compromise and get things done as quickly as we can, with as quick readouts as we can for the efficacy of the vaccine, to look for some side effects. But again, the true efficacy and the true dangers of some of these therapies and vaccines will only be known after they're deployed at large scale.
Thank you so much, David, for that response. So right now we're gonna we have some questions that we would like to ask to both David and Nele. And one of the things that we would like your opinion about is, what do you think, or what milestones do you think that we need to hit before we can start thinking about a post-COVID society? Or maybe David, you can start. So the question is, what are the milestones? What are the tools, and what is the information that we will need before we can actually start thinking about leaving the curve?
Yeah, this is a lot of this has nothing to do with it's advised by science, but it has nothing to do with science. It has to do with politics, economics, and behavior. And we heard Nele show a lot of curves. The frightening thing about this this particular virus is that even when you're through with that surge and you get down to near baseline levels, at any time it can you have that exponential rise back, and if you don't clamp down, the danger is that once the prevalence in the population is too high, it's very hard to get back down to baseline levels. So I think that for me the metric is stable, low baseline levels, where the disease is there, but over time we have enough time to scale and deploy vaccines so that we can get the herd immunity that Nele talked about earlier.
And also I think, the mouth masks, they can really help to have a life which is kind of normal, because people can still go out and they're still not used optimally. Not in the States, Belgium, kind of, certainly not in Sweden, but then it's just such a normal thing to do it in the Asian countries, and it really helped in those countries. So because we see that there are waves and they are somehow seasonal, but it's probably not really a temperature or climate related. It's more social behavior related, because indeed summer break is over, people come back, then they go back to work in public transport. So it's indeed trying to control the populations, which is a big challenge, and especially with a lot of misinformation out there as well.
Thank you so much, Nele. We also received another question for David. As COVID-19 is found in multiple tissues, do we know whether there are other known pathologies besides COVID-19 affecting the lung? And should we interpret these cases that we do see popping up as a rather an outlier, or is there evidence that COVID-19 can indeed have multiple effects besides what was originally thought of?
So we know that the virus can infect multiple tissues. It can affect the brain. There's neurological diseases. One of the most prevalent issues with what Nele called long haulers is that they don't have the clarity of mind that they did prior to becoming infected. There are blood disorders. So even though the virus does not get into the blood, except in very rare cases, there are blood disorders that occur as a consequence of sort of the downstream effects of the virus. There's gastrointestinal effects that occur. The virus does, there are receptors. The ACE2 receptor is the receptor that the spike protein binds to and enables the virus to get into cells, and those receptors, while they're highly prevalent in the lungs, in the mucous membranes, they're prevalent in lots of tissues, and therefore they infect. They have the potential to infect lots of different organs, and these are not rare cases. That it's I would say that one of the things that has happened with COVID is that just about every specialty at the hospitals have gotten called into the pandemic because of the number of patients that are exhibiting all these different effects.
Thank you so much, David. We also received another question for Nele. So David just talked about antibody tests and tests that can detect the antigens on the virus or viral RNA. Which of these tests would be best to focus on to track the curve?
Well, I think especially the acute infection. So because the immunity, it's already too late. And we still don't know yet how long it will last. So I would, or the RNA, or indeed the proteins, the direct testing. Oh, it depends also on availability. If you have the sequencing platforms available, that because we need capacity. So yeah, that's a bit my answer. Any of both techniques, not the immunity, but then large scale testing.
Thank you, Nele. And I would maybe ask one final question to both speakers, and that's we were wondering what would be your next step or your planned research in the future that's involving COVID-19. In what field or what area do you think you will manage your efforts?
Do you want to start, David? Or, well, yeah, I'm now involved in a project that's actually organized by, coordinated by people from Boulder University, and they're looking into how science affects policy in different countries. So I think they have now 10 or 20 countries on board and see how it worked well or didn't go well. So this is going to be quite a big work, and in the meantime, I keep my efforts in trying to have transparent communication and hopefully have some impact on the Swedish policy, which is often not very scientific, science-based, unfortunately. Some of the things.
So my lab is working on new diagnostic tests that have better analytical sensitivity, meaning that they can detect lower concentrations of antibodies, lower concentrations of antigens. And one of the things that we're working very hard to do is really to understand the issue of infectivity and how that correlates with both the PCR test, the test for RNA, and the antigen test. I've been speaking publicly for probably 6 months now, just giving my opinion that I think the antigen tests are probably more predictive of infectivity than the molecular tests that are considered the gold standard. And the reason that I say that is that we have very good evidence showing that as soon as a person, so as we look at samples from people who get infected, their antigen levels go up, but then as soon as they start producing antibodies, their antigen level goes down, which is exactly what you would expect. And our thought is that as soon as those antigens disappear, it means that the virus, that the immune system is now clearing virus. And unfortunately, what's happening is that when it's clearing virus, what that means is that it's destroying the virus, but it's releasing the RNA from the virus, and that RNA can still be detected. And we think that those are just false positive tests. When people go in, they get tested, they get a positive RNA test, but they're probably not even infected anymore as long as their antibodies have converted. So we're really trying to understand how to use all the tools that we have available, the molecular test for RNA, the protein test, the antigen test, as well as the antibody test to really be predictive of who's infected, who's infective, and who's protected.
Thank you very much, David. And with this, I would like to thank our speakers in name of the Harvard MIT Belgian Society, Nele, Brusselaers, and David Walt. Many thanks for this wonderful talk and your vital research. As a little thank you, David will receive a box of pralinen of Neuhaus, named after the inventor of praline, Jean Neuhaus. And we will send Nele a box of goodies from artisanal dessert specialist Goût du Roi. We also want to take some time to thank our consulate in New York and Consul General Frank Geerkens, the Honorary Consulate of New England and Honorary Consul Anne de Koning, and Flanders in the USA and Head Delegate Yves Wantes, and Wallonia Brussels International and Managing Director Pascal Delcominet and Delegate Maxime Van Counter for their support and their help in sharing this webinar.